So our first, and this is a huge honor for me to do this, our first topic, for our first speaker, we have Dr. Khan Alaptagin with us. He will be talking about neurofeedback as a resource for mental health in children. Dr. Khan is a research associate in McLean Hospital and is an instructor in psychiatry at Harvard Medical School. Dr. Khan has worked with the Red Cross at UNICEF in conflict zones where he's developed an interest in PTSD, and neurobiology in trauma stress. After gaining experience in neuroscience, Dr. Khan joined McLean's to develop the biopsychiatry research program led by Martin Etch to focus on the neurobiology of trauma and adversity. He is also a fellow at the Royal Society of Public Health and holds a visiting faculty appointment at Shifa Hospital, Islamabad, and the Lady Readings Hospital in Peshawar, Pakistan. It's been an amazing honor for me also on a personal level to know Dr. Khan, and his support as well to bringing neurofeedback into Pakistan. We hope to sort of like allow this platform to be one of the first steps in actually introducing this. So I bring this sort of like table, this whole experience up to you. Yeah.
All right. Okay. So can you enable host sharing, please? Screen sharing, please. It says host has disabled screen sharing.
Sure thing. I just asked my team; they'll be just doing that. Could you check if that's if that's worked?
Yes. Can everybody see the screen? Is it visible to everybody?
Yes.
Okay, perfect. So I spoke, well, first and foremost, and actually let me turn the timer on so that I can, I don't get sidetracked a lot. So thank you for the opportunity. When I spoke with the moderator, Onali, we realized that although experts in the field, most of our panelists are not familiar with the statistical evidence and the situation, the current situation of trauma-related services in Pakistan and what actually the demographic is going through. So I kind of changed the agenda a little bit, where I want to basically make a statistical case for why we need trauma-informed mental health care in Pakistan, what's being done, and then I'll talk at the end about neurofeedback and why we wanted to bring neurofeedback to Pakistan. So like as Onali mentioned, I'm affiliated with a couple of places. Now, I usually, as they say, a picture is powerful than 1,000 words. I usually start with this slide. And many of you will think that this is basically just different resolution or like pixelated differently. But on the left, it's brain cells. It's a picture of a brain cell, which is just 1 micron wide snapshot. On the right is actually the picture of a universe. So this is how beautiful, intricate the brain can be. At the same time, as you can see, if it's not being taken care of, on the left, it's a normal brain. On the right is a 3-year-old orphan's brain who had suffered extreme neglect. This is from the same group, and they found out that a severely neglected brain, extremely neglected brain suffers significantly when it comes to positive relationships, when it comes to brain activity, brain power in the frontal and the prefrontal area. So coming back to the topic, right now the situation is such that the mental disorders are increasing at a rapid rate. COVID has only accelerated this process. And mental disorders right now are a distant first in global burden of disease in terms of years lived with disability, and also in terms of disability-adjusted life years. Close to 500 million people right now suffer from depressive disorders. Mental disorders, neurological and substance-related disorders increased by 41% between 1990 and 2010. And what's more troubling is close to 1.5 million people committed suicide in 2020, of which 73% was in developing countries. Despite these troubling numbers, very little assistance is given to non-communicable diseases globally, and mental health receives just close to 0.4%. Many of you are familiar with this. Many of you who are here are familiar with these issues, the common barriers: poverty, strife, lack of resources, lack of education. Then on top of that, if it's a country like Pakistan or some country in like West Africa, you get conflicts with terrorism, there are mass migrations, disasters like flooding, and these just add to the problems, and people actually focus on temporary solutions rather than the long-term well-being of the society. It's a vicious cycle. Poverty and mental disorders interact with each other on multiple levels. And this is a very old slide, but unfortunately, the numbers have not changed much. High-income countries, looking at the situation currently, are not investing enough. But when it comes to low-income and middle-income countries, the investment in mental health is really, really worrisome. And as a consequence, you get an enormous mental health treatment gap, mental health treatment gap. Even in high-income countries, 44 to 70% of patients don't receive treatment. In countries like Pakistan, it can be anywhere from 85 to 90%. And other example of lack of resources, as a comparison, in United States, the number of psychiatrists is 28,000 for 330 million people, while in Pakistan, the number of psychiatrists for 218 million people is approximately 500 only. So why study trauma and stress in populations that have already so many issues to deal with? Because it's almost ignored on the global mental health level. This is coming from someone who has spoken to multiple champions of global mental health, global health, and it's just the nature of things. The vast majority of research on social determinants of mental health has been generated from high-income countries. Up to 90% of research is conducted in high-income countries, while the main problems are actually in low-income countries. So I often say that if you have a magical wand and if you can just wave it and get rid of adversity and trauma, specifically early adversity and trauma from the society, you can get rid of 78% of IV drug use, 67% of suicide attempts, and 54% of current depression. We know this from the landmark Adverse Childhood Experiences study. They basically asked 10 basic questions, and they started in 1997 about these different forms of early adversities, and they found out a linear relationship. So the more adversities you had, the more trauma you had, specifically in early childhood, there was more risk for depression, more risk for IV drug use, more risk for attempted suicide. As treaters, as providers, it's worth noting that on the same scale, people who had more than who endorsed more than 5 adverse events, they had a 10.3-fold more risk of more chance of receiving a prescription for antipsychotics, and a 17-fold in a risk for receiving a prescription for mood stabilizers. Additionally, a mind-boggling finding was on the same scale, if you had more than 6 adverse childhood events, there was a nearly 20-year reduction in the lifespan of that population. So if you think about this, globally speaking, and how childhood abuse and trauma is connected with these mental disorders, it's a critical missing factor in the context of global mental health. The A study was done it was started in 1997, and they've been following those people since then. But a replication happened in 2011 of almost 50,000 US adults, and they found that an A score of more than 4 was associated with so many medical conditions, like, as you can see, diabetes, stroke, cancer, risky HIV behavior, depression, and all that. So looking at these medical disorders and the childhood adversities, childhood trauma, you will realize that this is something that's a critical missing factor in global public health as well. Now, many of you might know this, like 90% of world's children live in low and middle income countries. According to WHO, 1 in 2 children, which is basically over half of all children, 1 billion children ages 2 to 17 experience trauma in one form or another. It can be direct in the form of physical, sexual, and emotional abuse, or indirect in the form of witnessing violence in homes, schools, and communities. So it's not a surprise that mental disorders are the leading cause of disability among children and adolescents globally. The WHO survey conducted of 52,000, close to 52,000 adults in 21 countries ranging from low to high income. They found out that childhood adversities specifically associated with maladaptive family functioning, for example, child abuse and neglect, parental mental illness, were the strongest predictors of mental disorders globally. So when it comes to Pakistan, every country has its own story to tell. Specifically in the context of trauma, Pakistan suffered $126 billion losses due to terrorism in 17 years. And this is, like, I'm not even talking about the deaths and like so many unaccounted for factors. Furthermore, 2.8 million people were displaced. One should note that as many as 40% of refugees meet criteria for PTSD. Floods displaced 14 million people in Pakistan between 2008 and 2013. One study by Sana et al. Found that 91% respondents had moderate PTSD. Mubin et al. Found that 59% of respondents had PTSD. Dennis Charney's group at NYU, they did a survey in 2013 of the 2005 earthquake affectees, and they found out that 65% of the people still had probable PTSD. What we see currently in the mental health landscape in Pakistan, the patient population is around 70% female, of which 46% are children or adolescents. The commonly diagnosed problems are neurotic, stress-related, and somatoform disorders, so the link with trauma can be seen there. Inpatient admissions are primarily because of affective disorders and stress-related and somatoform disorders. According to numbers from Aga Khan University, 50 million, of which 20 million are children, require psychiatric treatment. Postpartum depression is highest in South Asia. In 2 studies, relatively recent studies, they found up to 80% prevalence of antepartum depression. Both postpartum depression and antepartum depression are strongly associated with trauma and adversity. A study by Thomson Reuters Foundation found that 53% of girls, 34% of boys between the ages of 15 and 19 think that it's okay to hit your wife or partner under certain circumstances. Up to 90% of women in Pakistan experience domestic violence in one form or another. So this is extremely critical because it's a cycle that keeps repeating itself. Young girls who experience abuse are more likely to experience further re-victimization in adulthood. Pregnant women who are victims of intimate partner violence have a 4.1-fold and 5.8-fold risk for moderately severe and severe depression. Compared to pregnant women with no childhood abuse, the odds of PTSD increase by 3.1-fold, with just physical abuse, 5.3-fold for sexual abuse, and 8-fold for both physical and sexual abuse. Antenatal depression, which I just made the case, like 80% of antenatal depression, even though the global numbers are between 20 to 25%, increases the risk for maltreatment in the offspring by almost 4 times. Children who have been exposed to both antenatal depression and child abuse are at almost 12 times greater risk for developing psychopathology than the offspring not so exposed. And I think it was in 2017 in Biological Psychiatry where they found out the intergenerational impact, in the sense that women with childhood maltreatment history, their kids had low intracranial volume. So Pakistan also has one of the highest dropout rates. So in addition to being witnesses to domestic violence, in addition to being a victim of parental aggression, our children actually go through significant amount of trauma in schools as well. It's higher, severe in nature. 89% of public and private schools in Punjab were using corporal punishment in one form or another, according to one study. In another study in 2014, they found out that 70% of teachers agreed that corporal punishment was useful for disciplining students. It's worth noting that there is a significant correlation between corporal punishment and school dropouts. Also, a meta-analysis, I think it was a couple of years ago, they found out that children with corporal punishment are about 24% less likely to be developmentally on track. These things are associated with each other because Pakistan has one of the highest rates of stunting in the world at around 43%. So how are we approaching all this? We are approaching this through like multiple angles. One angle is through trauma prevention, where we are basically, there is this project, Onali and Mariam are part of that, where we are, it's a national level corporal punishment prevention project in public schools in Pakistan called Interactive Competencies with Children for Teachers. We are also working on awareness raising through some certificate programs, diploma programs, a child abuse prevention certificate. And also we are providing treatment services such as neurofeedback for children and adults. So if you, I'm an advocate, but if you talk to advocates of neurofeedback, they would say that this is a brain exercise and this is good for pretty much every single brain-related disorder out there. I like this definition. There are many, but it's basically neurofeedback is EEG biofeedback, which is a means of operantly conditioning the rhythmic electrical manifestations of CNS regulatory function by challenging the brain to shift away from unstable firing patterns toward more homeostatic ones. So one of the reasons, and I'll get back to this, one of our practitioners has this approach that if you become, like for instance, mindfulness, if you become more aware of your breathing patterns, you can control it. Similarly, if you can become aware of your own brain activity, you can change it also. So, yes, okay. The jury is still out. There are now FDA approved devices as well. I think there are now, there was in 2014 or 2015, a review was published. There are thousands of studies which have looked at so many aspects of neurofeedback being beneficial for children, for adults, for attention deficit hyperactivity disorder, for autism spectrum disorders, for anxiety disorders, for depression. But at the same time, the number of skeptics is the same. There are many people who are still skeptical about the efficacy of neurofeedback. So there are some studies which we have taken as beacons. One of them is this one. It's relatively old. It was in 2006, but they found out that the after 30 sessions of individualized QEEG guided neurofeedback, there was a significant improvement in externalizing problems, internalizing problems, social problems, aggressive behavior, thought problems, delinquent behavior, and so on. Similarly, in 1991, they found out alpha theta brainwave activity was helpful, efficacious in the treatment of PTSD and prevention of relapse. And Bessel-van-der-Kolk, so I basically belong to that group. And they did the first randomized control trial of NFB for complex PTSD and found that compared with the control group, neurofeedback produced significant PTSD symptom improvement in individuals with chronic PTSD, as well as in affect regulation capacities. So I still say that the evidence, because if you look at the reviews, there are many people who are strong proponents of neurofeedback, but at the same time, there are, like, as I said, skeptics as well. However, our experience is the reason I wanted to bring neurofeedback to Pakistan was first, it's not as resource intensive as other things. Secondly, the culture is not like therapy is still something that is the people are there is a sense of introversion. People don't open up that easily. So therapy is still evolving. People are learning now. So neurofeedback in comparison is much more mechanistic. There is a process happening. You see the process happening in front of you on computer. So that was very appealing to me. And I was like, this is something that can work. So and it's cheap comparative to other, like for instance, at Lady Reading Hospital, they procured a TMS machine 5 years ago through like a funding, and they never used it because neurofeedback was more available, less resource intensive, and it was once a week as compared to TMS being 3 or 4 times a week. So through a collaboration between the Foundation for Neurofeedback and Applied Neuroscience, ANS Foundation, NeuroCare Foundation, we launched 2 neurofeedback therapy centers in 2018. We have treated almost 500 plus patients suffering from major psychiatric disorders. And unfortunately, because of IRB, because of the other complexities, COVID also interfered with a lot of things. We have not been able to do a specific study on trauma-related disorders in children. But this year, we started a randomized control trial, which is going on right now on NFB versus conventional pharmacotherapy and psychotherapy in OCD patients with histories of childhood adversity. So that's basically what I wanted to talk about. And right now we are in the process of kind of expanding. We want to actually bring it to the Trauma Release and Wellness Center as well. And the more people know about it, the better it is. Like, as I said, I'm an advocate. I've seen a lot of these things happen myself. I personally treated someone over 8 weeks, twice a week, who had shot himself 8 times. He was a severe drug abuser. Then his mother passed away, and he was psychiatrically severely suffering. By the time we were done, I'm not sure how much of that can be attributed to neurofeedback, but he's functional now. He has a job now. We have treated people with substance abuse histories. We have treated people with long-term treatment-resistant depression. We have treated geriatric populations who were prescribed ECT, and they didn't want ECT, so we treated them with neurofeedback, and actually the results were similar. So one skepticism is the quantification of neurofeedback. A lot of people are not happy with how it's quantified, but at the same time, if you look at qualitative information, if you look at your clinical population, you realize how much it affects. It's like psychotherapy, because like it's very difficult to quantify what happens in the therapeutic process, in the psychotherapeutic process. Similarly, with neurofeedback, you may not be seeing a lot of difference there, even though there are ways to quantify it. But what you hear from your patients is how you guide the next session and the next session and the session after that. So that's basically what I wanted to talk about today, why we want to focus, why it's kind of becoming critical to approach trauma-informed therapy, trauma-informed services in Pakistan from this angle, and also what options are there and what can be done more. Thank you.
Thank you so much, Dr. Khan, for this talk. I really appreciate you sharing these things. If you guys have any questions regarding the conversation that we've had, we have the team. I would appreciate you guys to just put it on your chat box. That would really help. And then we can sort of like select a question, select a person whose question we can ask, and they can come in on the panel, and they can comment on the screen, and hopefully they'll be able to ask the question directly. So we're just going to wait for that. Hopefully we can stop the screen share.
So can you see, should I just answer the questions here, or should I just read them and then answer them?
If you feel like you would want to just ask the question, I can read our questions out, and hopefully you can sort of like just answer them. We have Mariam Anwar. She's asking, when is neurofeedback technology coming to Karachi?
So it's it's not just even the other day we have an orphanage, a government-funded orphanage in Peshawar, and the principal emailed me asking for the device and how they can basically start doing it. And I was explaining to her that it's not just about neurofeedback. It requires supervision. The person, the therapist, has to be certified with a certain number of hours. I have to actually supervise them for a little bit, because every patient, every therapy is individualized. You have to treat it on individual basis. And like the same thing can work for someone, but it cannot work for someone else. So, and it's not like a medication. So the therapist, it's a, I often compare it with a tango. So basically, let me give you one example. We have an arousal checklist that was developed by Ed Hamlin. He's kind of our pioneer in this area, at least for our group. And we have an under arousal, over arousal, and mixed arousal checklist. So when a patient comes, they go, they do that, they fill out that checklist, and then we know whether to target the left side of the brain or whether to target the right side of the brain, and then accordingly. And then the only way for us to know, yes, we can see the z-scores and how everything is happening in the, but we rely more on what the patient is telling us. So like, for instance, I treated someone here at McLean who was severely depressed, could not sleep. I did one session and then she slept for 16 hours the next day, which is also not, but that's how people can respond to these kinds of things. So the point is, yes, we do want to bring it to Karachi. Onali and I talked about it actually last year, yes, and he was planning to come to Peshawar to observe the whole thing. Like when I brought neurofeedback, we trained 25 people in at Lady Reading Hospital. I brought a master trainer with me to Lady Reading Hospital. It was psychiatrists, neurologists, psychologists. We trained them for 1 week, and then some of them continued practicing it. Some of them couldn't find the time. So it's a process, but we are working on that now. What is the efficacy of neurofeedback? That's as broad of a question as I can think of, because in what context, whether you're talking about depression, whether you're talking about treatment-resistant depression or bipolar disorder, or so for instance, let me give you an example. For children specifically, the most, the disorder for which neurofeedback has been tested mostly is ADHD, followed by autism, and or ASD. So many studies have found efficacy. Some studies have found out, like for instance, there is a recent study, you can find it online, where they found out that it was based on parent reports, and in the treatment arm, they didn't find much difference. There is another study where they found out that neurofeedback was as efficacious as Ritalin for treatment of ADHD. So it depends on how you're defining efficacy. It depends on how you're looking at it. And that's, and again, like as I said, there are people who say that the stimulus should be yoked. There are people who are not in favor of like what kind of a sham is being used or in a study. Also, it's very difficult, unfortunately. I've been in the system for a while now. It's very difficult to get funding for randomized controlled trials of neurofeedback. So yeah, that's the thing. However, I can share, I have a PDF. It was put together by a very nice lady. Actually, I have to give her credit for this. So she did it for, I think, BCIA, Synthis Karsan PhD. She compiled a list of neurofeedback, BCIA neurofeedback studies and their efficacy. So it's basically a list. I can share it with the moderator, and then anyone who's interested, they can look at that. And it's basically a compilation of all the disorders that have been studied using neurofeedback. Any long-term studies showing lasting benefits of NFP? Yes, there have been a couple of studies. They have found that the results were pretty much sustainable for at least 1 year. So that's a good thing. You will find it in that compiled version as well. Treatment of multiple disorders. How would you rate neurofeedback in comparison to other treatment methods? If you can share some more relevant info, that would be great. Yes, I'll share that uh, uh, bibliography and with the moderator, and they can share. It's a PDF document. Treatment of multiple disorders. Yes, that's what we have been doing. And I'm actually writing a paper on this. I'm a guest editor on a special issue on trauma-informed mental health for Journal of Pakistan Psychiatric Society. And one of the articles specifically is on why neurofeedback has been so successful in Pakistan as compared to the more skeptical Western cultures, let's say the US. And it has a lot to do with the like in Pakistan, there is more belief in what's happening, the doctor is doing something good. Similarly, there is less skepticism in terms of the treatment modality. So we have tried it for a bunch of things. We found it to be very effective for treatment-resistant depression. We found it to be very effective for substance use disorders. And we also found it for anxiety disorders. It was only effective when we coupled it with psychotherapy. So that's one thing to note. I have case reports. We treated someone with severe history of childhood sexual abuse. And I think it took us a year, but by the time we terminated, she was very functional and actually like doing very well. So yep, what else? How would you rate neurofeedback in comparison to other treatment methods? Basically, I would again say that it depends on, so it's considered to be one of the most benign, like in terms of side effects, I can say that there is literally none. What can happen mostly is like if you treat the wrong hemisphere, you can get a little bit aggressive or excited, or you can also feel down if you're talking the opposite of that. But that's pretty much the end of it. If you think about psychotropic medication, can you give it to someone who is pregnant? No, you have to be very careful about that. Can you give it to someone? Like one of the things about children and neurofeedback is how parents are often worried about long-term consequences of having your kid on pharmacotherapy if your kid is suffering from ADHD, like Ritalin and these kinds of things. In neurofeedback, that's not a problem. Similarly, with ECT, we treated a 65-year-old. They were recommended ECT because they were treatment resistant, and they didn't want to go through the pain of ECT. So it took longer with neurofeedback, but it worked. So you have to look at the consequences as well. The treatment is individual and also is individualized, and also the circumstances are individualized. Email us any for, okay. I think that's
wonderful.
Is there any international, just one last question, is there any international body that monitors research-based efficacy? BCIA. So yeah, it's BCIA. You can, and also the document I will share. It's all BCIA-based studies and all that. So yeah.
Wonderful. Thank you so much, Doctor. I think it was really wonderful, especially to get to see a lot of interest coming from the people here about neurofeedback. I think that was really wonderful to see, and how people have many questions. We are hopefully any further questions, they can email us. I think the email has been provided in the chat box, and we'll just definitely refer them on to you. Thank you so much for your time. I know the time difference between Boston and here is quite a lot, so definitely thank you so much for being here, and thank you for sort of like participating in the first International Trauma Recovery Summit of Pakistan.
Absolutely.